And the title of this is Key Abstracts from the Veterinary Cancer Society meeting. So the idea behind this talk came to me as I was sitting in that meeting a year or so ago, and realized it's like, wow, this stuff is really cool. It's really interesting. You know, every year we hear about all of these great advances, all of these things that researchers and doctors and pathologists and clinicians and everyone's working on. And they come and share their work with these abstracts, and we always leave that meeting with this sense that there's all this great information that's going to come out. Unfortunately, as many of you may know, some of that holds true, where that abstract goes on, becomes a research paper, and gets published in a journal, and then becomes privy to the veterinary community. And then, unfortunately, some of it doesn't. I've collected data and done research myself and then never published it. And I think that occurs more frequently than we'd like to say. There's a lot of effort that goes into writing those papers, and sometimes it's challenging to get them accepted to journals. And sometimes it's residents working on work that may or may not use that for their journal publication to get board certified. The point of it is that there's a lot of great information out there that I get to see and that many of us get to see when we go to these specialty meetings. So I thought, why not bring that to light and share some of that with the general practitioners that I work with, so they get to have an idea of what's going on and maybe what some of these new advancements that are. So that's what we're going to do. So we're going to actually start each section with a little review of some real key diseases, and then we're going to dive into what's new and what's exciting. So to get started, the first question is what is the Veterinary Cancer Society? The Veterinary Cancer Society is our, as oncologists, key specialty group. And it basically is a nonprofit organization that consists of medical, surgical, and radiation oncologists, but it's bigger than that. It really consists of anybody who wants to be in it. So internists, pathologists, as you can see, general practitioners, students, residents, interns, technicians, lots of them join us every year for our meeting. It is, quite frankly, the largest gathering of any oncology group in the world. And it has one simple goal, as you can see here. It's to bring together all the veterinary specialists in oncology and the biggest and brightest, and have us all share our information and what we're doing in the ongoing fight against cancer. So every year that meeting is held in different locations, and there are, without question, many, many great things that come out of it. Tonight's goals, again, is to review some of the gold standard treatments, really to hit on what are, with those common tumors, what are the current recommendations, as well as bring to light, again, new developments, unpublished findings, and then this ongoing work in the discipline of oncology. Also, I want to provide a platform towards the end for just questions and discussion as we get to the end. If anyone, when we have questions at the end, if you have a case or you have something that you just want to throw out to everybody in the room and say, what is everybody doing with that? Feel free to do that. A little bit of an outline of how I'm going to hit this. 3 big tumors that I'm going to really focus on are the 3 big ones right now that are really getting a lot of the most attention in research, a lot of the most attention with clinical trials. So that's lymphoma, osteosarcoma, and mast cell tumors. Mast cell tumors and lymphoma are really right now getting a lot of research because they're just so common in our veterinary oncology world. And then osteosarcoma gets a lot of attention every year because it is considered in humans to be a juvenile disease. The average person that gets diagnosed with osteosarcoma is usually less than 20. And so it's unfortunately a very challenging disease. So rightfully so, those juvenile diseases, leukemias, lymphomas, osteosarcoma, they get a lot of attention in our world as well. The other section that you probably will enjoy just as much as those will be just cool stuff. The stuff that I listen to, I'm going to give a little bit of an update on the melanoma vaccine and melanoma, hit on some hemangiosarcoma, and then even talk about a couple things, everything from a supplement or two to acupuncture to some things that I thought, well, that's neat, I want to go over that. We'll start with lymphoma. Just a real brief kind of run through. Really common tumor type, so 15 to 25% of all the cancers that are out there in the canine world are going to be lymphomas. It originates really from any of our lymphatic tissues, so lymph nodes, spleen, thymus, bone marrow, and ultimately in the canine world it's considered a systemic disease. So lymphoma in dogs is comparable to non-Hodgkin's lymphoma in humans. We rarely see Hodgkin's type lymphoma in dogs. Hodgkin's type would just indicate that it's more of a localized form of the disease. So when we see dogs with lymphoma, the majority of them will certainly be more systemic. The common signalment is a middle to older age dog, 6 to 9 years. There's not really any sex predisposition. Breed, there is. We all know those common breeds of boxer and golden retrievers. I always hit on this because these are a couple of the ones that you may not hear about as much. Bull mastiffs, basset hounds. And then this is interesting. A lot of people don't know this, that there is a reduced incidence of lymphoma in dachshunds and Pomeranians. So if you have anybody who owns a dachshund or Pomeranian, that can always be something you can throw out there and say, well, the good news is you have a reduced incidence of lymphoma. The common types that we see, the most common one obviously is the dog that comes in with large lymph nodes, and so multicentric lymphoma. GI lymphoma, cutaneous lymphoma, mediastinal, and CNS are all other types that are common ones that we run into. Multicentric lymphoma, though, is that common presentation. The treatment of choice is, because it's systemic, is going to be chemotherapy, with the most common chemotherapy protocol it being a multi-drug CHOP-based protocol, or as a lot of people refer to it, the University of Wisconsin-Madison protocol. It involves 4 drugs, so cyclophosphamide, doxorubicin, vincristine, and prednisone. And it's considered a first-line treatment, meaning that it's what we pull to first for virgin lymphomas. It is certainly utilizing the drugs that we think are considered the most effective, and it has the highest response rate and certainly the most success in treating these guys. We do have lots of dogs, though, that go through that treatment that obviously relapse or come out of remission at some point. That is where we step in and utilize second-line therapies. So second-line therapies basically mean that you've just failed a previous protocol and we're going to something to quote-unquote rescue you. Lomustine is one of my go-to second-line therapies. It certainly is one that I use quite a bit. I think it does have a very, very high efficacy, and a lot of dogs will respond to that really well as a second-line treatment. Whether they're B-cell or T-cell, this seems to be a very reasonable choice. Improved survival times with lomustine has been seen with some of the T-cell diseases and some pilot studies and some initial studies that we're going to hit on in a little bit. One of the big ones is cutaneous lymphoma. Oftentimes will be a T-cell origin type of lymphoma, and we do see some improved rates with lomustine, so that is one exception. If I have a dog with cutaneous lymphoma, oftentimes I will actually use lomustine as my first-line therapy with that, because I see a lot of success with the drug. It is not considered an optimal first-line therapy for multicentric unless there is a scenario where an owner declines CHOP-based or multi-drug protocol, and there's 2 reasons for that. One is that you're putting all your eggs in one basket. You're really using a single agent in that scenario, so if you respond to it, great. If you don't really have a combination protocol to help you out. The other is that the drug is given on a Q3 weeks schedule, and so if you respond to it, great. If you don't, now you've got a dog who's got a drug in his body that really you need to wait 3 weeks before you can do another chemo treatment, and it can present a pretty sticky situation if you're a dog that's have a progressive form of lymphoma. So one of the reasons why this drug doesn't make that CHOP protocol or that first-line therapy with a lot of multicentric lymphomas is because of the time that needs for you to recover from the first dose, and certainly in the big scheme of things, it's a great drug, but that really presents a problem if dogs are not responding well to this. The drug is typically given with prednisone and plus or minus L-spar as a rescue agent. Another common second-line treatment that I use is MOP. It combines a multi-drug protocol that's really hitting on some different drugs that are not seen in the CHOP protocol. The main one is going to be Mustergen, and Mustergen or mechlorothiamine is a compound that is a kind of a nasty drug, and you won't see a lot of people utilize this in their clinic because of it. So it actually is the same compound that's found in true mustard gas, and that's where the name comes from. It is powder, and when you get it, you reconstitute it. So this is one that if you ever use this protocol or use this drug, you really have to improve your safety or really think about safety. The main one is going to be you don't want to mess with that drug without a chemo hood, just because of the exposure and the previous known effects that it can have on people. But MOP is a good first and second line therapy. It's a nice second line therapy because it is a multi-drug protocol. It can be given on a weekly basis. So all of those things that we talked about with lomustine, this drug is not affected with that. And it does seem to have good success with B and T cell. Even in some studies, T-cell, it seemed like patients responded really well to this, even compared to going head-to-head with CHOP. They did just as well or even a little bit better with MOP. But it's kind of a tricky thing to use because, again, this is one of those drugs that does have an increased toxicity. Owners are really looking for safety, and certainly that's why it's not always used as a first-line treatment. Prognosis for lymphoma. I put in yellow there, those are your typical B-cell lymphoma dogs. We see at least a 90% response rate when you start treatment, and we see most of those dogs pass a year. So typically what we'll see is about 20 to 25% of dogs that are treated with a multi-drug CHOP-based protocol will reach 2 years. The decision-making number that I give clients, and I tell them these numbers, and I say, but if I was you sitting there today, what I would make my decision based on is 1 year to 14 months, because I think that is where I expect to get those dogs. I think that there is a large number that will reach 2 years, but it probably is about 25% of the cases I treat. So for decision-making purposes, I feel comfortable with them making a decision to move forward with chemo at that 1 year to 14 months. Rescue protocols are very different, so they're not going to have the same response rates. These dogs have been heavily pre-treated with chemo already, so their response rates are going to be 40 to 60%, and we're going to see anywhere from 1.5 to 3 months typically with different rescue courses as you're going forward. So not as attractive. But if we're looking at those dogs who have already achieved a year to 1.5 years, and we can get them another 3 months, it might be certainly worth doing. What's new? The biggest thing that you'll hear me talk about in a lot of diseases right now is immunotherapy. And immunotherapy is the next, without question, you can ask 1,000 oncologists, they'd all tell you the same thing. It is, without question, where we're going with oncology right now. The immunotherapy field is exploded in human and veterinary medicine, and actually veterinary medicine is probably leading the charge right now. With immunotherapy, there's 2 forms of it, and I'm going to explain both of them. There's passive and active. And both of these are really looking at vaccinations that will utilize the body's own immune system to help control these diseases, either in a passive manner where we're asking the immune system to just come in and help with the disease, or an active where we're actually stimulating the immune system to be more effective and ramping it up. The current immunotherapy for lymphoma is a commercially available vaccine that we utilize here in the hospital. We do have it here, and we are using it. We've only got 2 or 3 patients that have received it so far because it is new this year to treatments, but it is something that we do have and we are using. But it's called the Canine Lymphoma Vaccine DNA, and it's a conditionally licensed vaccine by Marielle. So the same group that did the melanoma vaccine did this. This is, and I'm going to go through a lot of details here, but this is a drug that has a couple things you got to know about it. The first is that this is used to keep dogs in remission once they achieve remission. So that means you get diagnosed with lymphoma, you go through your standard CHOP-based protocol. Once you're in remission and you're doing really well, you finish your protocol out, then we actually give you the immunization to try to help your immune system keep that disease under wraps, keep it under control. Unfortunately, it is only right now available for B-cell lymphoma dogs, and I'm going to explain that in more detail. But it has to be very much tailored to ask the immune system what to attack, so the current vaccine is only for B-cell. They chose that just because it's a more common disease. We see 2/3 to 3/4 of dogs diagnosed with B-cell if they have lymphoma. And it's given very simply as just 4 transdermal injections using that same needleless applicator that you will see with several of the feline vaccines that are out there. So it's given once every 2 weeks for 4 treatments, and it's really safe. There's just currently no adverse effects like with the melanoma vaccine that has been documented. So you don't really have to worry about nausea, vomiting, diarrhea, anything like that. The vaccine quintessentially is considered a very safe treatment. How does it work? Well, this current one is passive immunity again. And so what that means is that it is asking the immune system to help control lymphoma. Normally, the immune system cannot recognize B cancer cells or lymphoma cells as foreign. They're very similar to your normal lymphocytes. And so, as I say here, this really presents a problem in the body defending against cancer cells. CD20 is a marker that you can actually ask the lab to stain for to determine if you have B or T cell. And it's a common marker that's found on the surface of lots and lots of canine B cells, particularly malignant lymphocytes. So the canine lymphoma vaccine is produced using a DNA-encoded mouse CD20 or murine CD20. And the idea behind it is that you put this DNA mouse CD20 into the dog, and the body will say, that's not my CD20, that's not me. So the body will recognize that that murine CD20 is different enough from the canine CD20 that an immune response is generated, basically. These antibodies that then the immune system produces against that mouse CD20 is actually not that specific. So these antibodies that are produced will go and find the mouse CD20 and the canine CD20, leading to destruction of the mouse cells that you put in the body, but also the cells that are carrying that malignant CD20. And so that's how the disease then asks the immune system, clear this, and by the way, clear this while you're at it. The passive aspect is we're not manipulating the immune system in any way to ramp it up. We're just saying, this isn't supposed to be here, help us clear it, and in the process we clear potentially the malignant lymphomas. So the vaccine to date is, what do we know about it? Well, we know that it's very similar to things that are already being utilized in oncology, such as the Marielle DNA vaccine for melanoma. And it's the same concept, same model, different marker, particularly looking for surface markers that are on melanoma cells, but same concept, same passive immunity. CD20 vaccines have been utilized in non-Hodgkin lymphoma in people for years, and they are considered extremely effective. So the pilot studies that were done for this before it hit the market really showed that there was a significant improvement. The most important thing is it said, this is a high safety profile. You're not going to have any adverse effects, so there's not a lot to lose here. And more importantly, when we started to put it in, the results really shocked even the people who were doing the study going, wow, this is even better than I thought it would be. So what happened was we saw with these, and this is not a large number of dogs, but in this pilot study that had about 10 dogs in it, we saw that those dogs had this really elevated improvement in their median survival time. So 50% of the dogs hit 2 years. We were seeing 25% of dogs hit 2 years. So if this holds true, then that passive immunity held those dogs in remission potentially a year longer than what they should have held with chemo alone. So the passive immunity is out there. I think the biggest hurdles with it right now that we're running into, if we start to look at what are these hurdles, well, I mean, you have to have a B-cell lymphoma. So T-cell dogs are kind of out of luck. They don't get to receive it. The other thing is that there are a lot of dogs, even with B-cell lymphoma, that start going through CHOP and they're doing really well, and then they come out of remission before we get to the end of it. You really got to make it all the way through your protocol and be holding your remission. And the vaccine takes 4 to 6 weeks to generate an immune response if I start giving it to you right after you end your chemotherapy protocol. So you got to get all the way through your 6 months of CHOP, and then you got to stay in remission for another month, month and a half while I'm getting the vaccine there generated. Now, theoretically, if you follow the rules of median survival time of a year, you should be able to do that. But there is a pretty good number of dogs that will either not have B-cell lymphoma or will relapse during their treatment course, so this is not going to be a great option for them. The major hurdle right now is there's just not very many cases reported. So as more cases are generated this year, I'm sure there's going to be a lot more information in this upcoming meeting with dogs that were treated. This vaccine really became commercially available around February of this year. So as a year or two goes by, we're going to see that. And statistically, we'll get to see, is there a difference? I mean, that's the big thing. I mean, if we start giving it to them this year, I mean, those dogs should have stayed in a year, so we need to say, I'm saying 2 years. So that's why these things sometimes take time to get the data where you can go to a client and go, yes, you're absolutely going to get twice as long as we do this if we don't. So I think that the pilot studies are super exciting. And the next thing I'm going to tell you as we talk about active immunity, even makes it more exciting. But certainly these are where we're headed. We're not looking for new chemo drugs right now for lymphoma. We're looking for these types of things to keep dogs in remission.
What's the downside to giving it earlier in the treatment to get it ramped up?
Well, a lot of it is that when we start to treat these guys early in it, and this is a little controversial because some people believe this occurs, some people don't. Some people think that we'll suppress the immune system if we give it to you early and then keep you on chemo. A lot of people don't feel like this is going to be enough to clear heavy burdens of disease. So even though your lymph nodes shrink at week 2, 3, or 4, I mean, those dogs still have quite a bit of lymphoma in their body. If you stop treating a dog with lymphoma as soon as his lymph nodes shrink, he'll be back in 2 weeks with big lymph nodes again. So the reality of it is you ride that fine line of knowing we want to get as much chemo as we can in there to get this to the lowest level of disease possible. And that's where that CHOP protocol came up with 6 months because we knew that's where we're kind of plateauing. We got the disease as low as we could in the body, and doing more chemo won't help us. But it's the reason why we don't do 3-month protocols, is because we know that those dogs will relapse a lot earlier. I think that those studies have to be done to say, well, what if I just did 3 months and gave the vaccine? Right now we're saying, all right, we know this gets you in remission. We know this gets you a year. That's a proven time frame. So if I add it, what will I get? But, I mean, I think that the controversial thing is, if I give your vaccine really early, will I affect its effectiveness with suppressing you with chemotherapy? Or would it be just as effective? A lot of times we look at that in people and say it would affect you because we suppress you so heavily with chemotherapy if you're a human. But dogs, we really don't. I mean, dogs, we suppress their immune system, but I tell people all the time, I mean, we watch a blood count drop for 2 days and then come back up to normal during its nadir, and half the dogs never even drop below the normal range that we're treating. So that's the controversial thing. And I think that, again, it's a good question. It's a really good question because certainly that would take 2 or 3 of those things we just talked about completely out of the play. And so I think you'll see those studies done, as time goes on. So then there's active immunotherapy. Active immunotherapy right now involves a marker called CD47. So CD47 is just another marker that we have in our body. And it actually is something that regulates or kind of keeps in check your normal macrophage phagocytosis. So the idea of it is that CD47 suppresses that macrophage phagocytosis so it doesn't run at a real rampant rate. The idea here is that if we block CD47 as an agent, we would be able to then really allow macrophage phagocytosis to just take off. And you kind of allow that immune system to be way more effective. So right now what we're looking at is, can we give CD47 and CD20 together vaccines and make this a more effective treatment? So right now there is active clinical trials looking at that. And CD47, CD20 expression, passive and active immunity, that's what they're looking at, giving it together. Does it make that vaccine even more effective? Multiple ongoing clinical trials. This will likely significantly alter prognosis because we already know with CD20 what we're doing by itself, so CD40 blockage will just allow the immune system to be even more effective at clearing these diseases. There's certainly markers that have been proven. It certainly looks like something that's going to work. But this is the reason so much of this. So you ask, like, wow, there's a lot of stuff going on. It seems like they're putting a lot of effort into this. And this is one of the main reasons right here. Because right now, I mean, there's remarkable similarities they're finding between dogs with lymphoma and humans with lymphoma. And so this kind of stuff, when we can block CD47 and get CD20 immunotherapies going, this is going to allow veterinary treatments to become kind of a hallmark for that human care, those people that are diagnosed with lymphomas. And it is really exciting. When you go to these meetings and you hear people talk, you're like, yes, put that on the market tomorrow. And you really feel like it should. And I think I see these dogs that are not doing well and they've not made it through and they come out of remission. But, I mean, it certainly is the first time in a long time with lymphoma that we're seeing these big steps. I mean, before we were really stuck at a year, and now we're really seeing these dogs go 2 years all of a sudden. And that's an exciting thing. But CD47, CD20 immunotherapies, you will hear more about it. Big thing right now on our side of it here at MBS is that we do the lymphoma vaccine. We do have it. We have that passive immunity. If you have those clients that you've treated with chemotherapy or that you're sending to me and you think, these are the clients that would really put what they can into keeping that dog going, that is a vaccine I would do in my own dog. I mean, there's no question. Based on what I've seen on these studies, I'm like, this makes sense. It's expensive. So, this is a question I always get, and I'm not afraid to approach it. The vaccine's about $2,500, I mean, when you give it. And so it's an expensive treatment. And it sounds expensive, but Marielle has a ton of research and development in it. What makes it expensive is I don't think $2,500 or $2,600 or $2,700 is out of the realm. It's just that they just went through CHOP. They just went through chemotherapy, and so that's what makes it a struggle. It's not that we don't have clients that spend $2,500 a lot. It's just on the heels of the chemotherapy. So, yeah, it's a discussion.
Not each.
No, the whole thing, the whole course, yeah, the whole course. But when you do that whole course, they send you the box, and that's where it is. They're looking in this first year also to say, all right, we got a lot of research and development. We need to recover that. What's the manageable number that clients can do? But I will tell you, when I talk to clients about it, I would say this. If they plan on rescuing the dogs, if they plan on doing lomustine or a MOP protocol or another round of CHOP, we'll spend $2,500 pretty quick. I mean, if we start trying to do chemo on your dog every couple of weeks, trying to rescue you with chemotherapies in those settings, those rescue settings that might make you sick, you're having to do extra blood work. I mean, there's no CBC needed for a vaccine. I mean, it's just go home. And so that kind of thing in perspective, I think $2,500 is doable for those cases, and it may be worthwhile, especially if we can come out and show that is going to keep you from having to go through multiple rescue courses. And so I think it's doable, and I think the numbers will come down. I think it'll get cheaper as time goes on. The melanoma vaccine, I think, will be getting cheaper really soon because they've now had it out for 10 years. And so it's, they usually get about a 10-year patent on it, and then it'll start to drop. But these are, there are hurdles with it, but these are things that I think certain clients here that we would like to use it in more. If you have those cases, don't hesitate to call me about them. Moving into the immunotherapy, I wanted to throw a couple things in about diagnosing lymphoma. So I've talked to you guys a couple times about this. Flow cytometry is really a great tool that we're going to. We're not really biopsying a lot of lymph nodes anymore. A lot of people do, and it's fine if you do. It's still extremely effective. But we've been able to move away from surgical procedures to gain B and T cell differentiation. Flow cytometry is super easy. If you're not doing it, I can definitely tell you about it or give you a link to show you how to do it. It is once you do it, you'll do it every time. It's not a problem at all. But you're aspirating a lymph node. You're just putting in a little red top tube with a ml of saline and 1 drop of their serum after you spin their blood down, and you send it to the lab. You don't have to make slides. You don't have to do anything. And they can run a whole gamut of stains on that. So they're not limited to one stain for T cell, one stain for B cell. They can stain that sample that you send them. And all you're doing is literally aspirate the lymph node and squirt it directly in the tube. This looks like you're squirting snot in the tube when you're done. Put some saline in it, drop a serum, send it to the lab. They can run that flow cytometry on it and basically expose it to a whole gamut of different markers. And the idea behind it is it can confirm you have lymphoma because it looks for this homogeneous population. Are all of those lymphocytes the exact same? They're all stained the same, or are they different? If you're reactive, if you're trying to fight off some invading substance, you're having an immune response, you're going to have a bunch of lymphocytes that are different. If it's homogeneous, you have cancer. So it takes the human, I think it's lymphoma, maybe it's emerging lymphoma. It takes that pathology stuff out of it. It just says that's what it is. And then it tells you by the markers what you have. Is it B or T cell in one fell swoop? Diagnosis and tell you B and T cell. And when we send this to the lab, it's pretty close to the same price as if we sent out cytology to kind of give you an idea. So it's not a real expensive test. But this is the new thing. It also tries to start classifying these cells, not just as lymphoma or B and T cell. It starts classifying them in groups, saying, what's different? In humans, there are tons of subclassified lymphomas. You have T cell, you have B cell, you have intermediate, large, small cell. You have what's called T-zone. You have something called B-cell-rich T-zone lymphoma. All of these things carry different prognoses in people, and they're certainly carrying different prognoses in dogs. We've all had dogs with B-cell lymphoma that came out of remission really early, and we've all had some that lived for 3 years. Why? What's the difference there? So subclassification is what their guys at Colorado State University. And Colorado State University, I didn't go there, didn't do my residency there, but they are awesome. They do a lot of oncology work. And CSU, in their immunology diagnostic lab, particularly does a lot of work. And they are doing right now this subclassification of lymphoma. This is where I send all my flow cytometry because they bank everything I send them. They look for these markers, and they're really trying to determine, is there a difference? So they did a research and presented it. 75 dogs with B-cell lymphoma, never been treated, first time diagnosed, and they compared those flow cytometry results to histopathology. So they actually did flow and did a true cut biopsy on the lymph nodes on all these dogs. Findings all supported that in all cases they were able to confirm lymphoma without question, which is what we anticipated. But then they said, hey, what is the difference? Is there a difference? And it's a pretty big difference. They found that if you look at the cell size, the bigger, the more poorly differentiated, the uglier that cell looked, the worse prognosis you had. So if they classified you in this large cell group, and they actually had a measurement number, if they classify you as large cell lymphoma, which a lot of pathologists will put that in your report, now whether that's on a base measurement or this what they thought they saw that day with their eyes, when they say it, they feel like that's your prognosis when we're telling that to clients. So this may be a big deal. That's not a small group of dogs. It's 75 dogs they looked at. So the idea here was 75. They went through them. They said, hey, is there a difference in prognosis? They polled the people and said, how did they do after they went through their CHOP protocol? They were all treated there at CSU, so they were able to do that. And what they found was that if you had that large cell diagnosis, your median survival time was 6 months versus 12 months. So this may be prognostic information we need to know to help guide clients, as well as, remember, these were all B-cell dogs. Those dogs aren't going to make that vaccine. Because their prognosis was 6 months. So again, this just helps us learn more on how to prepare owners, what to tell them, and certainly how to approach these cases. Also, if we look at lymphoma, like many diseases, we also look at why do you get it in the first place. So we talk about diagnosis, we talk about treatment, but why do you have it? This can get really complicated. I'm going to try to simplify it, because I remember when I studied this for my boards, I was confused for like a week. But but I'll try to make it as simple as possible. So epigenetics and genetics are two different things. But epigenetics are thought to be they're stable heritable traits, meaning they're pretty much always passed on. And they're heritable traits that when they're passed on, they do cause a change in your gene expression, meaning they are responsible for something that is always there. It's like I'm going to have 5 fingers on my hands. And it's always going to have 5 fingers in your hands, and it's always going to get expressed if you have that trait. Epigenetics does change, though, and it can change from person to person and dog to dog. One of the big epigenetic things that we can look at on chromosome is called methylation. And that's just where a methyl group is added to your DNA. You will have those. Those are normal things to have, but it absolutely affects how your DNA is expressed if you have multiple methyl groups. So what we looked at was golden retrievers that seem to have this increased risk of lymphoma. Was there a genetic or epigenetic difference in those dogs? And what they found was, compared to a normal control group, there was a substantial difference in their methylation. And there was 438 methylated groups on their DNA versus 355 in normal dogs. It was a lot. I mean, it was a big difference, big different number of methylated groups on their DNA, and it's certainly not something anyone anticipated to find. But these were all dogs that had lymphoma, and it was found in every dog that had lymphoma, and it was found in, and these were also golden retrievers, by the way. It wasn't in the golden retrievers that didn't have it. So this is certainly something that may lead to an early detection model. It may also lead to us being able to test golden retrievers and go, don't breed that dog. I mean, that dog's got a hypermethylated DNA, and that's a bad sign for lymphoma. And certainly might even become a target one day for drugs. But this is the kind of stuff where we're actually now looking at screening dogs. It's not just treating. We're saying, how do I pick up that dog that has hemangiosarcoma? How do I pick up that dog that has lymphoma before it even happens? And this is the kind of stuff that they're looking at right now. So it's very scientific driven, but I think it's interesting to show that there are differences. And I think it's interesting to show when you get those questions like, is this genetic? Yeah, it is. I mean, it definitely is. A couple little ones I want to kind of toss in here. This is on, so this one here is a little bit different. So this is just basically looking at GI lymphoma. The reason I throw it in is because GI lymphoma is a form of lymphoma that's really tough. I mean, it's a tough one. Bad prognosis. We see that it's about 77 days when treated with a multi-drug CHOP protocol, which is not great, obviously. This study looked at 24 dogs that had confirmed histologic or cytologic GI lymphoma that were treated with lomustine instead of CHOP. And so they were given 70 mg per meter squared once every 3 weeks. I usually do 60 to 70, so that's a kind of a bigger dose for us. But 60 to 70 mg per meter squared, 24 dogs that were treated. We had 7 dogs in that study that went into a complete remission, had 8 dogs that went into a partial remission, and then there were 9 dogs that had progressive disease or stable disease. They didn't really respond very well. This is important because I'm going to explain this. The median survival time was only 70 days. So if you stop there, you go, well, that's no better than CHOP. One, it's a lot easier protocol than CHOP, though, and you got comparable numbers. But the other thing is if you broke out the dogs that had responses, they responded for quite some time. If you had a complete response after that first treatment or so, you stayed in for almost a year. That's huge compared to what we're doing up here. If you had a PR, partial response, then you stayed in for about 130 days. What do I take from this? I think that lomustine is a legitimate first-line therapy for GI lymphoma. It's either going to do comparable to 70 to 77 days, or you might have, if you have a complete response, you might have a more withstanding remission. How would I use this? I would definitely, if I used it, check that dog after the first treatment before I do the second one and say, did you respond? If you didn't respond, I'd get you off of it and go somewhere else, because the dogs that didn't respond didn't live very long. The dogs that did respond, now if I check you and you had a good response, I'd say, all right, we're sticking with this because these guys could get 350 days. So that's kind of the idea. Again, lomustine, GI lymphoma, it was just one of those that's something new that we're looking at. Quickly, LOP, as I told you, MOP, and I know these are kind of funny names, but we have to use acronyms a lot. The LOP is really looking at, no one likes to handle estrogen. What if we take it out and we give you lomustine, vincristine, procarbazine, and pred as a T-cell first line? And this actually was a really exciting talk, and it's got me wanting to use this more in T-cell lymphoma dogs. With CHOP, we usually get about 5 to 8 months with T-cell lymphoma. I mean, it's usually that 6-month dog, or that 5 to 8 months is what people talk about. And these guys, they used 31 dogs that had never been treated before with T-cell lymphoma, and they went through this protocol instead of our standard CHOP. Great response rate, 97% overall response, 88% of dogs went into remission. So we know those virgin lymphomas, they should respond to this. The median disease-free interval was similar, 5.8 months. So 5 to 8 months, 5.8 months, they were in that ballpark. But that just means when you started to see progression, these guys went on and continued treatment, and they lived for 10.7 months. So that's really exciting. That's better than what we had done previously, and so this protocol is a good protocol. I will tell you, that's a heavy protocol. Lomustine, procarbazine, vincristine. The way we give that, just to kind of give you a heads up, is we give all of these at the same time. So you get lomustine and vincristine on the exact same day. You get procarbazine daily every day, and procarbazine is kind of like Leukeran or Cytoxan or a low dose of lomustine. It's an alkylating agent. So we're giving this every day for 2 weeks. We're doing lomustine and vincristine, boom, boom, together. So those dogs, they have a higher toxicity profile. I mean, this is a heavier protocol. It's one of the negatives to it. But the response rate was good, and times it could potentially even exceed what we saw with CHOP. So with T-cell lymphoma, the point of this talk is that we are getting better at treating it and learning more about how to do better there. And the last thing in this section was looking at something that I always get questions about, so I like to put this one in there, and I thought this was a good talk. In this study, they looked at cats with GI lymphoma. So very common. We've been talking about dogs, but cats oftentimes get GI lymphoma. They can have small cell, intermediate, or large cell. Small cells, absolutely. The treatment of choice is still Leukeran or chlorambucil and prednisolone. Dogs with chlorambucil and prednisolone for small cell go on and do very well, and we know they often have a real good response to that. But intermediate and large cell lymphoma in cats can be real challenging. There are a lot of clinicians that will do surgery on these guys. They'll go in and remove a mass out of that cat's bowel. And the questions that we always ask is, does that do anything? We know that this is considered a more systemic disease even in cats. A lot of times their GI tract is going to be involved in multiple areas. So surgery historically in the oncology community has been really reserved for obstructive masses or perforated lymphoma masses, ones where we say we better go get that. Although a lot of cats had underwent surgery, someone said, well, let's see if it is helpful or not. So 34 cats underwent surgery for primary treatment of their GI lymphoma. This is a retrospective case review, so these cats, had already been treated, and they just went back and pulled records. 18 cats had small intestine involvement, 7 cats had large intestine disease, and 5 cats had stomach involvement. Only 26 of the 34 cats actually survived to suture removal. That's not great. That means 23.5% mortality in the first 2 weeks. Those cats did not heal. They perfed, they opened up, they dehissed. That's important. That tells us that that RNA that you did, you had a disease you were trying to put together most likely. Some of them got chemo, and that kind of messed up this thing. I didn't like it too much because, obviously they went in and did chemo after, so it kind of skews your results some. But we do know the overall survival time was 213 days. It's not bad, but when you break it out, you had large intestine cats that did really well, 675 days, and then you had small intestine and stomach that lived 51 days and 96 days. So this study highlighted one, and this is exactly what they put. Their conclusion was it is very reasonable to consider surgery in cats with solitary large intestinal lymphoma, but probably stay away from the small intestine and stomach unless they're obstructed or perfed. This is exciting because it tells us, man, they didn't do very well with small intestine, but it allows you to go, however, that large intestine group didn't do too bad. They lived for a long time. So I do think that large intestinal lymphoma in cats is a different disease. I think it behaves differently, and you may actually have a more isolated area there in the colon where you can do something. But the small intestine guys, you just need to keep in mind, unless you just really think it's super isolated, it's probably got disease in that intestinal wall that you're trying to put together, and that's why that mortality rate was so high. So this does not mean don't go biopsy them. I mean, it just means that if you're trying to resect big sections of intestine, they may not have the outcome that we really like to have. So that's a quick thing, not that quick, but it was a good review on lymphoma. To kind of pick up speed, I'm going to go ahead and move into this osteosarcoma talk here, and the first section is just a review of osteosarcoma, so we'll go through it quickly. Osteosarcoma, Not as common as lymphoma, 3 to 4%. 85% of the bone tumors that we find will be osteosarcoma. So if you find a bone tumor, I mean, it's osteosarcoma until proven otherwise. And obviously the appendicular skeleton is where we see 75% of those. It is a locally invasive, highly metastatic tumor. We know that. We know it causes bone destruction and pain, and certainly we know the metastatic rate is high. So the reported metastatic rate for osteosarc is about 90%. If we look at metastasis, the most common location by far and away is the lungs, and then you can have some unusual locations like lymph nodes, bone, or other soft tissues. Age of onset, it's bimodal. This is really important to know, is that 7 to 10 years of age is the most common, but there is a peak in this disease that occurs about 1 to 2 years, so 18 to 24 months. Remember I said that osteosarcoma is a juvenile disease in the human population. There is a juvenile form of osteosarcoma in dogs that we will run across. I see dogs every now and then are 16 months old, 18 months old, 2 years old that have this disease. It's a smaller group, but it does occur. And it's been reported as young as 6 months. It affects the metaphyseal region of the long bones, meaning it doesn't cross a joint. It's not down in there in that area where the epiphysis is and where you might see arthritis. It's going to be a little bit higher up. And we see it more commonly in the front limbs, with the distal radius and the proximal humerus being the most common locations. It can be lytic, it can be productive, it can be destructive and lytic and productive. The pulmonary parenchyma is the most common location for metastasis. And if we look at it and we talk about it, again, 90% of dogs will develop metastasis, but only about 10% of patients will have this evident on radiographs at diagnosis. We diagnose dogs early. They are certainly getting painful. They have issues. Clients are very astute of if their dog's limping, they bring them in, and so we catch it, I think, before these metastatic lesions have time to get large enough to develop. It's definitely important to take x-rays when they come in because you want to know if you're in that group, but don't be surprised if you don't see them. Don't tell clients if you don't see them, oh, good news, we caught it early, it's not going to met. No, it probably will. 90% do. You just may not see them at diagnosis. The treatment, because of that high metastatic rate, has to involve two things. Control that bone destruction, that primary tumor, that pain associated with the tumor, and then try to step in and control metastasis. The treatment of choice right now, that's kind of the standard of care, is removal of the bone, so amputation, so surgical resection of that primary tumor, followed with chemotherapy, and typically we use a platinum agent. Most common platinum agent we utilize, and certainly the most common agent that we utilize across the board, is carboplatin. It's much less nephrotoxic and has less adverse effects compared to cisplatin, but it's also very effective still. It has comparable effectiveness to cisplatin. So neutropenia is its dose-limited toxicity. Dogs that go through an amputation and 4 to 6 doses of carboplatin should live a year. Basically see a prognosis of about 50% again of these dogs getting to 1 year, 25% to 2 years, and about 10% of bone tumor dogs that have an amputation in carbo will actually make 3 years. So it's a disease that I do see dogs that can do well with. So what's new and improved? The first one is, we talked about that bimodal age distribution. I have always been asked, well, my dog has osteosarcoma and it's really young, does that change their prognosis? And historically I've told people no. I've said, no, I don't think it does. I mean, I think young dogs can do just as well as older dogs. But I was wrong. A study was done that looked at this at 18 to 24-month-old patients, and it was multi-institutional because you won't see a ton of these. I'll see 3, 4, 5 of them a year and see lots of other older dogs with bone tumors. So they pulled a bunch of people to get 61 dogs. But what they found was there was a little different distribution. We always said the front legs are twice as likely to be diagnosed, and we also said the distal radius, proximal humerus. In this study, 25% of the dogs had it in their proximal tibia. So I'll be honest with you, I've actually seen a couple dogs that are really young this year, and they're in their proximal tibia. I mean, so it's a little bit of an unusual location. The reasoning behind it, the theory behind it, because I always kind of go wonder, it's like, why did that happen? Is this is thought to be a developmental disease, not so much of a wear and tear, stress-related disease. So maybe it is that area of the tibia really undergoes a lot of changes in development, and that's why it gets the tumor there. But proximal tibia was more likely. Distal radius was only 15% of the cases. 35 of the dogs treated were included in the actual category of looking at survival times of the 61 dogs. These are dogs that got amputation and carbo, got their standard, gold standard of treatment, and average survival time was only 170 days. So that's a lot different than when I tell somebody your dog should get a year, or even 25% of them get 2 years. Young dogs, certainly it appears from this study, and it was not a small group, it's 35 dogs that they looked at there, ended up having a worse prognosis. So at this point, we do think that young age may be a negative prognostic indicator, unfortunately, for these dogs, and that is what we say to people when they're diagnosed at a young age, is that it's a negative prognostic indicator at that young age. So that's kind of a bummer thing. Here's something that's kind of cool. We're going to talk about surgical treatment. No one wants to amputate their dog. And my dog was diagnosed with osteosarcoma about, I guess, 22 months ago, something like that, and she passed away this spring. She survived about 16 and a half months. She had it in her front leg, and I had to do an amputation, and I tell clients every day to do an amputation, and the day I had to make that decision, I was like, ugh! I didn't want to do it, but I did it, and she got another 16 months, and I was glad I did it, but it's not an easy decision. So when you look at amputation, we need alternatives. We need alternatives to it, because there are patients that clients just refuse to amputate or don't want to amputate. There are dogs that just aren't candidates, as we know, orthopedically, neurologically, weight. There's all kinds of things that play into that. And then there's locations that we just can't amputate. So mandible, maxilla, skull, vertebra, these areas get bone tumors as well. We do these limb spare procedures, but really there's only one location in the body that right now is accepted success, and that's the distal radius, because we can put an implant in there, plate it. But if you start talking elbow or up here in the shoulder or around the knee, those just have such a high failure rate that it's just not attempted. Reduced implant infection, failure, cost, just not being able to do it, all those things lead to, like, is there an option for us in the case of alternatives to amputation? In the world right now, there's a big push for 3D printing. And 3D printing, I know it's going to sound weird, you're like, where are you going with that? Well, 3D printing has historically, in my mind, always occurred to things like plastic, but they're actually able now to 3D print titanium and steel. They powder this stuff out, and then they can do 3D printing with it. And so there is a group right now in New Zealand that are making surgical implants out of titanium alloy powder with 3D printers. And what makes them really, really attractive is that they're based on that patient's CT scan. So it's an exact replica of what's coming out of the dog. It's a plug-and-play technology. Basically, they take your CT, they will put it in a 3D printer, and the 3D printer will make that exact copy of that implant. It's not a bendable plate. You're not plating on the outside. You're putting it into that area. So the current results, they've done mandibles, they've done radiuses, tibia, and this was last year, so they've done even more this year. And all of those dogs returned to normal function. One of the patients alive 2 years was good function. And this is huge. When we do steel implants in bone, for bone tumors, the infection rate is really high. It's about 40 to 50% in some studies even higher than that. In this scenario, titanium, really low failure rate, really low infection rate, 8% infection rate is all they're seeing with it. So really, really neat. This is an image of what it looks like, and I'm going to show you actually a video of it in just a second here. But this is an image of what it looks like, and these are just made on the end to attach it. So this is actually going in to take the place of a mandible. Instead of doing that hemimandibulectomy, they were able to put 3D printed mandible bone into this dog. If you're curious, we'll look at a video. Super cool. Super cool stuff. And I think if you caught there that when they 3D print these things, what's neat about them is that they're not flat plates. We can do a pin, we can do a plate. They're a round 3D bone. And the failure then is just not going to happen. And the bone grafts can go in them, the tissue can go through them, what she was saying. But when you see one of these, and he had some at the meeting when he did the lecture, these were the New Zealanders that came over and did it. They showed them in the bones, even like the tibias, they're like that big around. And it's all 3D printed out, and it's got the curves to it. I wish they showed the tibias and the radiuses, because that's what really was cool. We're sitting there holding like this flat plate going, all right, that maybe fits. This is a big deal. And what's neat about it is, and this is what blew my mind, is like, well, that's got to cost a fortune. And it's actually cheaper to make one of those with those printers than it is actually to make a flat plate. And so you can these 3D titanium printers. I mean, there are more of them. They're doing this down at Texas A&M right now. This stuff's moved straight into the United States. There's tons of 3D printing companies that are grabbing hold of it and saying, you know, I'm gonna do this. And so. Very interesting. This was out 2016, so this stuff's going to keep going. I mean, if we do a CT on a dog here, I would say that if it's the right clients and we can always check, we could probably call and say we want an implant made, and they'd send it to us. I mean, they're commercially making them, and like they say, shipping them overseas and shipping them to people. And there are people in the States that are doing them now. So I thought it was a very neat thing, and really was come home obviously excited about it. Another common theme, we're in the osteosarcoma section, and they're actually looking at immunotherapy for osteosarcoma as well. And this is an experimental vaccine that is currently undergoing clinical trials. Now, I'm going to hit on this again as just really selling that idea that immunotherapy is where the field is going. This is a little different vaccine. You know, all these things are referred to as vaccines, and ultimately none of them are preventative like we think about. They're really looking at more of treatment. But this particular one is somewhat preventative. It utilizes an idea that in the body there are certain factors that cancer cells need to actually make a successful metastasis. So to explain that a little bit more is there are millions of cells that break off of tumors all the time and get into circulation. And you take an X-ray and you see 6 nodules. So what happened to the other, whoever wants to do math really fast? But well, they just didn't make it. They didn't survive. So there's so many cancer cells that get into circulation that don't survive, and then there's the few lucky ones that get somewhere, set up shop, and actually turn into a nodule. GD3 and GD2 are something called gangliosides, and they are tumor antigens that are linked in human and canine cancer to play a vital role in migration and metastasis. So they're really thought to be what helps these cancer cells in osteosarcoma get into the lungs and develop into nodules and to help metastasize. So there was a clinical trial that was done, looked at dogs that were 2 groups. One got amputation and carboplatin, standard of care, and group 2 got amputation, carboplatin, and vaccine. This vaccine is really there to target this GD3, GD2, and what happened in this was really surprising. So the first thing is, all the dogs died of metastasis. So that was the bummer, but none of them actually died of lung metastasis. So that was really unusual. So what they found in this study was they were absolutely successful at stopping pulmonary metastasis. None of the dogs actually developed pulmonary metastasis. They died of weird stuff. They met it to the bone, met it to the kidneys. I mean, this was documented in 2/3 of the patients where they went to one of those 2 locations. So that just highlights, these are 2 things that the kidneys particularly, that I don't know if I've ever seen a dog met to his kidney. But it just tells us that they met it, but it went to a very different location. So we were able to target successfully something that prevented pulmonary metastasis. Now someone smart has to figure out, how do you prevent it from going to other places? But it did highlight that those markers work, and we can alter how dogs metastasize with this vaccine. But this one's a long way from hitting the shelves. I mean, this one is one where the dog still passed away. They just passed away something different. But it does highlight that there is an opportunity there potentially to alter metastasis and potentially down the road even prevent it. Molecular targeted therapy, the main one we'll talk about is Palladia. This is another thing that we're talking more and more about. This is really used, and of course you all know Palladia is being used heavily with mast cell tumors. It is not specific for mast cell tumor. It was marketed by Pfizer or Zoetis for mast cell tumors because mast cell tumors are just really common. And it happens to have a lot of similar markers, and it worked. But this drug can be used for lots of different things, and particularly this disease, osteosarcoma, has some of these VEGF, platelet-derived growth factors, some of these factors that really are important in its growth and metastasis. So Palladia is thought to be an acceptable treatment for osteosarcoma. It is not considered first line. It's really started to be used when you have METs show up. And so I've been using it in some dogs when metastases occur as a rescue treatment. These were patients that were treated, 23 dogs, and 14 of them had stable disease or improved disease in this first study, which was really exciting. That means we were able to slow that metastasis down. The study that was published last year, which was new information, was 20 dogs. They took that one step further, and they looked at 20 dogs and said, when you get metastasis, we're going to start you on Palladia. This was a little bit of a retrospective analysis. They went through and kind of went back and pulled the numbers. But what they found is that the survival time was only 90 days, but as they looked at patient to patient, there was this huge variation between individual patients. Some dogs with pulmonary metastasis, when started on Palladia, lived another 433 days. So it was wow. And then some didn't respond. Some didn't have much benefit and lived only 17 days. So what was the difference? Well, as they looked at prognostic factors, they found out very quickly that the size of your pulmonary nodules, the extent of your disease, was a big-time player in how well you did with treatment. So size of nodules became a negative prognostic indicator. If they were large, you just didn't do as well. If you were early Mets, you could do really well. So what we found here is a really important thing, and that is if you're going to implement a rescue treatment like Palladia with osteosarcoma, you need to do it when those metastases are small. If a client comes to me and their dog has really large pulmonary masses, metastatic disease from their osteosarcoma, this is likely not going to have a lot of benefit or help. If it's early on, there may be some efficacy there. I've had a couple dogs that I've treated with pulmonary metastasis that actually had complete resolution of them. They went away and held their remission for 8 to 12 months with Palladia. So I definitely think it works. I think it's important when you look at these studies to say, okay, this is that information that helps me with case selection on what dogs to use it on. This is something that I use a lot. So metronomic therapy is basically using low-dose frequent administration, meaning you're giving low doses of treatment, low doses of chemotherapy or an anti-inflammatory drug on a daily basis, very frequent basis. It has reduced side effects when you use it that way, but continuously keeps a concentration of drug in the body at all times. Most common drugs that are used are cyclophosphamide, lomustine, chlorambucil. Cytoxin is by far and away the most common one, and it's used concurrently with an NSAID. I use Lasix with it, and this just helps reduce some of the side effects we can see with Cytoxin. Prospective study looking at this in osteosarcoma patients. 21 dogs were treated with amputation and carboplatin alone. 18 dogs had amputation and carboplatin and metronomic, so it was 39 dogs total. The dogs that got a metronomic protocol, how that works, you did your amp, you went through your 5 doses of carboplatin, and then you started on your metronomic protocol afterwards. And they used a 15 mg per meter squared daily dose. I usually use like 12 to 13 mg per meter squared, but really it's just what number fits there. Significantly longer progression-free interval was noted in the metronomic group. So dogs that were started on that got 480 days survival, where the other guys got 331 days. And so that was a huge difference as well. These were dogs that picked up, quite frankly, another 150 days they wouldn't have normally got. I highly recommend considering metronomic treatment in dogs after they go through their carboplatin. It's easy to stop if they don't handle it well. It's cheap, and ultimately I personally in a clinical setting have seen dogs live a lot longer than they should. My personal dog had a really bad proximal humeral osteosarcoma. When she was diagnosed, it was large, it was nasty, and those proximal humeral osteosarcomas don't carry as good a prognosis. On average, they're usually about 10 months. And again, she went on metronomics after her carbo, did fine with it, and went on and lived about 16 months. So I know she picked up time, maybe 6 months, that theoretically, if you go by the books, really shouldn't have been there. So this is safe, it's easy, it's cheap, and I really think there's a lot of studies now showing that it's beneficial. So we'll jump into the last big topic, and that's mast cell tumors. Obviously, very common disease. It makes up 16 to 21% all the cutaneous tumors. Any dog can get it in terms of age. 3 weeks has been noted. I mean, that's terrible. 3 weeks, you got a mast cell tumor, all the way up to 19 years. This cause is thought to be somewhat genetic because we do see a lot of the usual suspects with mast cell tumors. Boxers, pugs, Boston's bulldogs, these English breed dogs, they definitely carry a genetic predisposition for it. There's also some genetic predispositions in German dogs, Weimaraners and Vizslas, as well as some of the labs. Presentation can vary greatly, as most of you know. It can be a large mass, it can be a small nodule, it can be a plaque. Can look a lot of different ways. They all release histamine and heparin and some enzymes that certainly can cause ulcers and rashes and swelling from time to time. Surgery is considered the first-line treatment. Solitary mast cell tumors, we always go in there and we talk about removing them. 2 to 3 centimeters is what they're still talking about on a lateral surgical margin, and 1 deep fascial plane trying to go in there to get a complete resection to say that this thing's not going to come back afterwards. A lot of times with that deep plane, again, you're not going 2 or 3 centimeters deep. You're getting a layer of muscle, layer of fascia. Getting that layer of muscle, layer of fascia allows you to get a deep margin. The lateral margins are really the measurements we talk about. Now, when you take 2 or 3 centimeters off at surgery and you send it to the lab, it's not going to come back and say you got 2 or 3 centimeters. So that's the big thing. A lot of people call me and go, well, it says I only got 1.5. that's great. I mean, you probably did get 3 at surgery, but that thing shrinks, pulls down. When you cut it loose, it goes whoop, and goes like that. So they're going to look at that, but ultimately you're never going to see probably a section comes back with 2 or 3 unless you took the leg or you got really wide. Most of these are going to come back centimeter, even half a centimeter, centimeter and a half. People ask me all the time, well, what do you do? I don't send dogs back to surgery for, if they've got a half a centimeter or more, and it's a lower grade tumor, we're going to watch it. I mean, to be honest with you, I educate the owners about it, but if we go in and we do 2 centimeters, you're probably going to get a centimeter at the most on your histopath report as it comes back. All tumors should be submitted, though, when you take them off for histology. You really want to know margins, but you want to know the grade of it, and we'll talk a little bit about that. Grading tumors, as many of you probably have recognized, when you send them in, you're most likely going to get a report that still says 1, 2, or 3, but then it'll have parentheses and say low grade or high grade. It's because we're moving away from the patented grading system, moving away from grade 1 tumors, 2 tumors, and 3 tumors, and we're going to a pure 2-tier system of low grade, high grade. And that's great. That's going to simplify everybody's life. You're going to know what to tell clients. You're going to know if it's bad. You're going to know if it's good. The reason behind that is a cooperative cumulative effort between oncologists and pathologists. There's actually an oncology pathology task force right now for mast cell tumors going on, where they're looking to do that, because there were so many dogs that we took tumors off, we sent them to the lab, and the pathologist said grade 2. And you know what to do with them. Some did well, some didn't do well. And so now it's went to this 2-tier system, and you probably will see the others phase out over the next couple of years. So just get comfortable looking for low grade and high grade. That's going to be real important, because that's what you're going to make your decisions on. The treatment after you remove one of these, if someone said, what is the gold standard? I mean, if you did not get a complete excision or it's really narrow, radiation therapy is the gold standard if you're a human or you just are doing everything there. It is certainly going to be something that can prevent more radical surgery, can prevent an amputation, and the most important thing is it's really effective. So radiation for a mast cell tumor, 85 to 95% control at 2 years. So we know it works. The cons is logistics, to be honest with you. The closest radiation facilities at this point in time is going to be Knoxville, the University of Tennessee, Atlanta, and Auburn, and University of Georgia. We send a lot of cases down to Atlanta. There's a lot of cases go over to Knoxville, but ultimately that is a lot of times a deterring factor for clients, is knowing they have to travel. It's not just about traveling. Making a trip to Knoxville is not a big deal, but these patients stay there for a month and they're getting 16 to 22 treatments. So unless they want to pack up and move over there, they have to leave their dog there for the month. And that usually is where my conversation gets stopped by the clients. They don't want to do that. But we do still send a lot for radiation for various tumor types. Cost of radiation is there. It's $4,500 to $5,500 by the time they go through a full month of treatment. So that can be a deterring factor, but honestly, it usually isn't. I mean, usually the biggest thing is the logistics side of it. I mean, clients just don't like that idea of the month-long separation. But what's the alternative option? Remember I told you there are going to be some narrow tumors you take off, no question about it. We used to say, man, if you didn't get it off or it's really narrow, it's going to grow back. And that was what I was taught when I did my residency, and then people started doing research, and they came out and go, maybe that's not exactly true. So a paper came out, not last year's meeting, but the year before, and they talked about wait and see. What happens if we have a narrow excision? You got half a centimeter to a centimeter. What happened? We only saw, at the most, with narrowly excised mast cell tumors, a 50 to 60% recurrence rate. Some of those dogs didn't even get close to a half, though. That study was skewed because literally they just included anybody that had 1 centimeter or less. So some of the dogs in that study had like 1 millimeter, 2 millimeters, like really narrow ones, 50 to 60% recurrence rate. So we know, even if you're getting that on histopath that's less than a centimeter, there's a good chance it may not come back still. And some of those dogs will go on and do okay. I talk to clients, say, okay, if it's low grade, your chance of metastasis is about 15% or less. If we're comfortable with that number, we take them, and we're not going to improve that by radiating the area. If it was going to spread, it probably did that early on. If it's an area where we can do surgery, you might hold that surgery for 6 months and see if it's going to grow back. If it did, you can do a bigger surgery or radiate it. If it doesn't, then you may have saved that owner quite a bit in terms of the stress on the client, stress on the pet, and cost of doing the second surgery. Alternative options, though, if we feel like it's just not a complete surgery, it's incomplete, is you can do a bigger one. We do a lot of these here. I bring it up because this may be something where people say, I'm not comfortable doing a skin flap or a graft, and we do them here all the time. We had one the other day. We just did big skin graft over the top of the head. I mean, those are things that I think where you go to a specialty referral practice that we can step in and do those bigger surgeries if it's a tumor that you just can't get margins on. And it's always surprising, even when I take the cases to surgeons and go, you can't get this, and they're like, yeah, we'll just take the tail and use the skin on the tail and wrap that around. And I'm like, oh, okay, yeah, I guess that would work. So there's a lot of creativity there, and that's where these surgeons come in. The idea here is I do think that, again, some of these narrow surgeries, if you're getting there half centimeter to a centimeter, it may be reasonable to consider this wait and see approach. If it looks like we're just completely did not get it all, and you're worried about recurrence, then maybe a more aggressive surgery would make sense. With high-grade tumors, different story. We're not so worried about local therapy. We're really talking about distant metastasis, and we know high-grade tumors can be up to 75-80% metastatic. So we treat those guys systemically with chemotherapy. There's two forms of chemotherapy, cytotoxic and cytostatic. So cytotoxic is your traditional chemo that you think about, vinblastine and pred, lomustine and pred. They both have similar response rates, 47, 44, so around 45 to 50%. And you're going to see these guys get out there somewhere around 5 months, 3 to 5 months, 3 to 6 months, with some of these really highly metastatic tumors. A lot of people talk about Palladia. Well, it's considered a cytostatic drug, and it's really important for everybody to understand. It means it halts cells' growth. It's not like the vinblastine and lomustine that's terminating a cancer cell. This binds to receptors and tries to inactivate it. So the question with it is there's a little bit of a poor understanding of what happens when I stop it and I release that inhibition. Does that mast cell tumor grow again, or does it stay down? Some of them will start growing again. And so Palladia for me is more of a rescue. A lot of people ask me that. I still use vinblastine and lomustine as first line, and I use Palladia as my second line treatment. So what's new? This is kind of just a slide I almost didn't put in here, but I thought it was interesting, so I threw it in. It was really looking at just incident rates of mast cell tumors. It was just interesting to me of what these guys actually, and tells us about the change in our profession. They actually looked to gather this information at insurance claims. There's that many insurance claims that are going on out there. So they looked at insurance claims and said, how many insurance claims were submitted in the United States on mast cell tumors last year? So they evaluated 16,785 insurance claims that were submitted in the United States. And what they found was there's a 1.56 incidence rate is what it was of all the insurance claims that were submitted for everything. In the UK, it was only 0.27%, though. So there was a substantial difference, and it raises the question, is that a real difference? Is there more people with insurance in the United States versus the UK? Is there a difference in veterinarians' ability to diagnose a mast cell tumor? But I think it's a substantial difference. 0.2 to 1.5, I think that number is real. And they certainly, when they gave this talk, felt it was real. The average age was 7 years. Boxers' pugs were on that list like we thought they would be. But they also found a big group of Swiss mountain dogs that made the list. And I've actually seen a couple of these guys over the last couple of years and thought that was odd that we're seeing multiple Swiss mountain dogs. Where this comes into question is that means, is this a genetic disease, and are we propagating it more here in terms of our breeding? Because the breeding in the UK is very different. Those dogs aren't getting neutered and spayed like they do here. There's more of kind of a genetic pool there. Here, we neuter everybody, and then purebred people breed purebred dogs. And so it seems like in some scenarios that this disease may not be getting bred out of the population. We may be even finding some dogs that it's getting bred into. Again, these are just totally my opinions, so don't feel like that's core facts. But I do think when you look at these incidence rates on some of these diseases, and then you look at how they're developed and what they're in, you do start to see that boxers still have mast cell tumors and continue to have mast cell tumors, and we're not doing a lot to change that. And that's kind of the concept there. Grading these mast cell tumors and diagnosing them. If we look at diagnosing mast cell tumor, most people are getting comfortable with looking under a microscope and going, those are mast cells, this is a mast cell tumor. But grading requires a biopsy. You need tissue. You need to be able to look at morphology of the cells, the mitotic rate. You're looking at vascular and lymphatic invasion. You're looking at cell degradation, tumor necrosis, invasion. There was a group of people, though, that says, pathologists, that said, you know what, I think we could actually get pretty close to grading these with cytology. what if we did that and compared it to histology? How close could we really get so you don't have to actually biopsy them? So they did 152 dogs, big group, and they had 3 different pathologists look at all 152 samples and see if the pathologists agreed and how close did they get to histology results. Obviously, cytology is easier, quicker, cheaper, less invasive. Dogs don't have to have surgery. They used a 2-tier system, and they just said, pathologist, is it high grade or low grade? And we're going to compare that to the histology results and see how well you did. So really with the cytology, the only 2 things you can really look at is the mitotic index, so how many cells are undergoing mitosis, and what's the cells look like, how scary do they look. They looked at that, and they did okay. I mean, I'm not going to knock them too hard. Their sensitivity to pick up a high-grade tumor was 88%. So that means that 88% sensitivity, they missed about 12% of the high-grade tumors as they went through. And they got 88% of them. If they said it was a high-grade tumor, though, they were pretty much on, because it was 94% specificity. We like to see these guys be in the 90s. 95 is kind of what you shoot for, sensitivity and specificity. So it was lower. They weren't as good. Some high-grade tumors got through that they classified in a low-grade category. So cytology is still looking to be inferior to histopathology when it comes to mast cell tumors, and so this was really met with their final statement was, you know what, we can get close, but we're going to miss some stuff if we didn't do a biopsy. So it's still required when you take these things off to send them in to get that grade. You're not going to see people grade mast cell tumors on cytology. They just won't do it. If we look at treatment, so treatment, as I told you, we've been real limited. Vinblastine, lomustine, prednisone, and now Palladia. I mean, those are really our drugs that we use for mast cell tumors. There's not like lymphoma. There's not this big list of rescue protocols over here. Lomustine is commonly used. I like the drug, but unfortunately it does have some toxicity profiles to it we don't like. Very commonly it causes neutropenia. Very commonly you'll see dogs get hepatotoxicity. This was a study that actually looked at 13 dogs with mast cell tumors, and instead of giving them lomustine on a Q3-week basis, they broke that drug down, compounded it, and gave it daily at 2.85 instead of 60 or 70 mg per meter squared, and gave it daily. And they did that for 4 months straight, and gave a little pred with it, and then evaluated how those dogs did. Blood was evaluated at 7, 14, and months, so 1 week, 2 weeks, and monthly after that. And really, the dogs did great. They had very little neutropenia. They only had 1 dog that had mild ALT elevation, and the treatment seemed to be equally effective going head-to-head with some of the previous studies that we've done. I like this. I thought that this was great because that tells me if I have a dog that doesn't handle lomustine well, maybe he's got hepatotoxicity or he's on lomustine and his liver ALT is going up, this could be an option to switch him to a compounded metronomic form of it and still be equally effective. And so this shows us that maybe that metronomic course could be utilized to be just as effective with less side effects. Mast cell tumors, lymphoma, osteosarcoma, lots of stuff, lots of information. I know it's kind of a whirlwind as I go through all this stuff, but obviously I just want to bring to light some things that I think are new and interesting. The last section is just kind of a catch-all for just key topics that I caught my eye going through the meeting last year. The first one is just a review of the melanoma vaccine. We use a lot of melanoma vaccine here, and if we look at the melanoma vaccine, there are some people that love it, and there are some people that say, you know what, I don't think it works. So Marielle has had it out now for 10 years. This was looking at the last 9 years, and they really just want to say, how effective is it? So this is from a few VCA clinics that pulled a bunch of dogs. There were 320 dogs, and they said, how did these dogs do? Well, some backstory here on the melanoma vaccine. When I recommend it, and the way Marielle tells us to use it, is they say for it to be effective, dogs need to have local control. So if you have an oral melanoma in the mouth, we need to get that under control first. And they shouldn't have metastatic disease. So basically get it to a microscopic low level of disease, give them the vaccine, and that'll help keep it regulated and keep them in remission, similar to kind of what we talked about with lymphoma. Dogs that are treated with that, they report that you should get 13, 14 months down the road successfully. If we gave those same dogs chemotherapy, historically they would get like 9 months. So it was great, sold everybody on it, and we started using it. Not everybody gets local control. Not everybody comes in doesn't have metastasis, and not everybody that comes in has an oral tumor. Some have digits. So how, when we put all that together, does it really work when you're actually in the real world? Well, in this study, 320 dogs, that's a pretty good number for veterinary medicine for sure. 66% of the patients, that is, had oral melanoma, 17% had digit, 11% of them actually had lymph node metastasis at treatment. And so it's not uncommon if you've got an oral tumor, if I poke that lymph node, even if it's not big, and look at it under a microscope, I'll see melanocytic stuff and say, this thing's in the lymph node already. Doesn't mean that you can't give them the vaccine. It just means you may not have local control. 39% of dogs were deemed not to have local control. Or 39%, had local control of the tumor, So that means that you had this huge number, 61% of dogs that didn't have local control of their tumor. So I'm starting to read that and think, well, these dogs, they're going to be, this number's not going to be what Marielle said, because their thing was like the perfect candidate, no mets, great local control. Well, it's not at all what they found. They found that if stage was prognostic, but all the dogs actually did really well with the melanoma vaccine. So to explain this to you, stage 1 is I have a small, less than 2 centimeter mass in my mouth. Stage 2 is I have a bigger mass in my mouth. It's starting to get bigger than 2 centimeters. Stage 3 is it's in the lymph node. And stage 4 is it's in my lungs. That's kind of the idea. So basically distant metastasis, regional metastasis, and then these two are based on your size of your tumor. The dogs that had small tumors, got them removed, they went on and did really well. As you can see, huge numbers. I would never tell a client that number. That number's wild to me. But I don't even know how many years that is. I was just like, I don't even know, how did you count that? So but I will say that it tells me that there are dogs out there that are living a long time with this disease. I mean, they're getting 2 or 3 years down the road with it. I think dogs that also, the study also tells me that when you have local control, you may do better, but if you don't have local control, maybe I should be using the vaccine more in those dogs and not just going straight to chemo. It also tells me that lymph node metastasis and local control is not a deal breaker. So I like this study. I think it tells us one thing without question, and that is that this vaccine has efficacy, and that's why so many people are pushing it forward and doing more immunotherapy. I think it also tells us that maybe they don't have to be the perfect candidate for us to give them the vaccine. If you have a dog that has lymph node metastasis, that's not a deal breaker. Send them over. We still probably in this scenario consider the vaccine. And the same thing with local control. Maybe not every dog needs a mandibulectomy and not every dog needs radiation. This may still be a reasonable option for them going down the road. Hemangiosarcoma is one that you won't hear a lot of people talk about in terms of these CE lectures, and a lot of it is just because there's not a ton of options for them. I mean, we know we take the spleen, or we know we take the mass, and we know we treat with doxorubicin and cross our fingers. I mean, there's metronomics, there's palladium, there's things we're playing with, but it's a nasty disease. This looked at a couple different things. One is, we know it's a nasty disease and we're not great at treating it, but what about preventing it or identifying it early? And so this is an inherited risk development study where they looked at multiple institutions, large number of golden retrievers again that had 204 golden retrievers with diagnosed hemangiosarcoma, and 268 healthy golden retrievers that were used as controls. Compared them side by side and said, is there a difference like they did with the lymphoma study? And what they did was they found that there was 2 loci on chromosomes that were substantially different time and time again in every one of those 204 dogs. So they knocked at every chromosome 5 and 3 loci. For all intents and purposes, you don't have to know what that means besides is that it was repeatable. And they were having it. And then they go to their normal golden retrievers and say, well, they should have it too. Nope, it's not there. So is that a difference? You better believe it's a difference. And the study feels like that it was an uncovered, very strong association between a genetic profile and hemangiosarcoma in the golden retriever. Golden Retriever is not getting a real good, at that meeting last year, didn't really get a good bill of health. I mean, they're saying that there is a genetic link in lymphoma, and they're saying there is a genetic link in hemangiosarc. These are things that we knew from mast cell tumors in boxers and pugs, and now it looks like that there is a link in these dogs, which is clinically what we see. We're just proving it. So if someone asks you, is this inherited? Yeah, I mean, it looks like it is. This number surprised me. In that study, if everything held true and they based it on what they're seeing, they said that golden retrievers could have up to a 20% lifetime risk of developing hemangiosarcoma. I mean, that's a big number. I mean, you've got a 20% chance that if you're a golden retriever, you could develop that, and we're not even talking about the lymphoma. You know, I love golden retrievers. I'd have one tomorrow. I just think that it's a situation where we know that these things have to be looked at, and again, I'm kind of jumping on that soapbox. I mean, we got to at some point go, we need some genetic variation. We need to start breeding these dogs that have these diseases, and we need to see if we can get some of this stuff out of the population. But I do think these studies do. I mean, they make you sit there and think, like, man, there's a reason why we shouldn't line breed. There's a reason why we need a genetic pool, and these are the reasons why. So I definitely want to talk about this because I get this question all the time. We use it all the time here. Probably you guys have heard about it and use it. Yunnan Biao is a Chinese supplement. It is something that is certainly becoming more mainstream, and people are using it certainly more commonly. The big thing about it is that it is certainly a supplement that's thought to improve coagulation, but no one's ever done any studies on it. Like a lot of holistic medicines, I mean, there's a lot of words that are put out there, but not a lot of studies necessarily that have said, let's prove it. But it doesn't mean it don't work. It just means that we don't publish a lot of papers from that side. So in this scenario, these guys did. They took 19 dogs with hemangiosarcoma. These dogs actually did not all have splenectomies, and a lot of them still had active tumors. And so, in fact, most of them had active tumors. I don't think there was like a couple. And this was the deal. They were paying for it, saying, let's just see if it works. So what they wanted to look at is, if we add chemo to slow the tumor down and give you Yunnan, will it make a difference in your risk of bleeding? In this scenario, they looked at CBCs and PCVs and PT and PTT, and they also looked at something called TIG, which is a thromboelastography, which actually is the most accurate way to test your clotting. And so they actually went above and beyond trying to determine how your coagulation looked. Day 0, 7, 21, 28, and 42. So the duration of this time frame was going to be pretty short here because these dogs, a lot of them still had tumors, and we knew their prognosis was still pretty low. And there was a difference. So if you're using Yunnan and you talk about it, there was a difference. And the idea behind it was that, what was their hematocrits looking like? Well, by the time they hit the end of this protocol, 28 to 42 days, there was not just a little bit, there was a statistically significant higher hematocrit in dogs that had Yunnan and chemo versus dogs that didn't. So microbleeds, chronic bleeding wasn't happening. I mean, something was different between those two populations of dogs. So I think the drug did slow down, at least in this study, the loss of blood from those tumors over time. We put dogs on that have heart-based masses. We put dogs on them that have a non-resectable hemangio or any tumor in the liver, anything that's bleeding, fluid effusion. I mean, you're not going to hurt them with the drug, and ultimately this study did show that there was a difference in hematocrit. The TIG actually did also show a prolongation of coagulation on the 3rd week in a lot of dogs, and so once you were on it for a couple weeks, there was a difference in how that coagulation worked. I can't tell you what panic nodo ginseng does to increase your coagulation, but it did make a difference, and it seems to be very safe. So the study did support a potential benefit, reducing tumor-associated hemorrhage, and so now when somebody asks you about it, you can say, yeah, there was a study on that, and that's the study. So it is something that obviously, like I said, you don't have a lot of some of those supplemental researches out there. You won't hear a lot of specialists come up here and talk about it, but we use this. We've been using it ever since my residency, and ultimately somebody finally proved that it does make a difference, and at least in this study it did.
So it's really not known to have any kind of side effects. It seems like getting in there and messing around with it.
Yeah, I mean, there's no question. I agree. I mean, I think there's a lot we don't know about it because, no one's ever looked at anything other than just clinically that those dogs do, have any outward clinical signs. Certainly didn't see anything on the CBCs, but they didn't do chemistries. They didn't do, major changes in terms of like how does the long-term affect the kidneys, liver, things like that. I agree with you. Like, does it increase your risk of throwing blood clots? Could you have coagulation changes where you start clotting and start throwing microclots? Pulmonary emboli, things like that. I've never seen it, but I've never used it in patients that, I take that back. I've used it in patients long-term as in months. I've never had patients that got it for years or anything like that. So, again, it's just a question there that was unanswered. Chemotherapy adverse effects in acupuncture. Acupuncture is certainly becoming a lot more common in the veterinary world. It's used a lot in human medicine. The top things when dogs are going through chemotherapy is that they do have at times some adverse effects, and it can certainly affect not just their quality of life, which this lists, but really cause treatment delays, causes to reduce doses, adjust their treatment course, and then ultimately may change their prognosis. acupuncture has been utilized in humans to reduce some of those side effects. The main side effects that they talk about to reduce is GI toxicity, and actually affects your immune system, your neutrophil count. So they looked at this in this 2-arm study with 25 dogs that had lymphoma. And the reason they chose lymphoma as a treatment course, because these guys are getting chemo every week. They get chemo every week for the first 2 months, and then every other week after that. So what they did with this study was really cool. They gave 2 groups, 25 dogs, they split them up, and basically one group got CHOP alone, standard of care, one group got CHOP, and every time they got Vinc or doxorubicin, they got acupuncture that day. And that was the 2 myelosuppressive drugs, and they wanted to give them acupuncture that day to see if it made a difference. Group 1 developed a significantly more likely to have dose adjustments. So that CHOP and that alone, it seemed like that those guys had to have their doses reduced because their naders were getting lower on their neutrophil count. And so their overall mean neutrophil was clinically different. It was about 1,900, where the group that got chemotherapy and acupuncture was almost 2,700. So there was a statistical difference there in terms of their neutrophil count. Now, there wasn't any survival difference. So acupuncture in this study certainly doesn't show it's going to make you live longer. But if you have a dog that has chronically neutropenic episodes while he's going through his chemotherapy, I would not hesitate to go, you know what, why don't you try to call acupuncturists and see about trying acupuncture, because we know it's not going to necessarily cause any negative effects in these cases, but it certainly did show, at least here, that it caused an increased white blood cell count, increased neutrophil count. Does appear safe, appears to reduce the need for dose reductions, and that's big if you're going through chemotherapy. Wasn't a huge group of dogs. I mean, it's only 25 because there's just not a readily group of dogs there that's getting acupuncture all the time. But I thought it was interesting, and I thought it was something that I'm always looking for an option to say, how can I make your neutrophil count go up without having to reduce your chemo all the time? And this was one of the first things that anybody presented to kind of had a solution to that. Cerenia, we're coming here to the end, guys, just a few minutes, but Cerenia is something that we use a lot here with chemotherapy patients. I'm sure you guys use a lot, and it is commonly labeled to be given at 2 mg per kg orally for 4 consecutive days and then take a 2-day break. So 4 days on, 2 days off, that's how it's labeled. If you get a box of Cerenia, there's 4 tablets in it. The most common thing we run across a lot of times when dogs are going through lots and lots of chemotherapy, especially like lymphoma, is that they can get nauseous. And maybe it's mild nausea, but it can be significant. And this was a really, really good group here that published this, a university. And they said, you know what, can you give Cerenia every single day? You have to take the 2-day break. So they took 40 dogs with lymphoma undergoing CHOP, and they just gave them for 28 days Cerenia every single day. Never gave them a break, never took off of it. And they said, you know what, we're going to see is it safe, does it work? And more importantly, we're actually going to check the Cerenia plasma concentration. So this is some of these studies that we don't necessarily can do in the clinic, but when they have a laboratory at a university, they actually drew blood on these dogs at all these times and said, where's your concentration? Where's your Cerenia concentration? So the good news is no dogs had any significant adverse effects to Cerenia. It seemed to be effective. And the plasma concentrations never actually elevated. So even when they passed that 4-day number and just kept giving it every single day, if anything, the numbers actually reduced a little. So 57 at day 7, 14 it was at day 14 it was 50 nanograms, and at day 28 it was 43 nanograms. So there was no drug accumulation. So if you got a dog that's just chronically nauseous and you want to use Cerenia daily, this does show that it's safe, well tolerated, and apparently no drug accumulation. It can be given daily. They market it as a 4-day, 2-day off. It's just a promotional thing because they don't think you need it longer than that. But every now and then we'll get patients that need it more. Don't hesitate to give it more frequently. Where I see this is like, you got a cat that's in renal failure or something's got pancreatitis and they're super nauseous, and you're like, I'm going to have you in the hospital more than a week or more than 4 days. I mean, you can definitely safely give Cerenia every single day. This was something that was new to me, and it is kind of that wave of cytology stuff and diagnosing. Right now, the conventional cytology is you take an aspirate, you put it on a slide, you smear it out, you heat fix it, you hope it looks good, you put it in your box, hope it doesn't break, and you send it to the lab. So, and then they send it back, and these slides look terrible. You did a horrible job. Now, I'm sure everybody says that you had a great preparation, and and then there's blood in it, and it gets hemodiluted, and you get a bunch of impurities. This is supposed to take all of that out. So this is what the human guys are doing right now. So this is actually a picture of cervical samples, but the idea behind it is that you can take a swab, you can take an aspirate. Instead of having to do any of that stuff, you can do what's called liquid-based cytology, where you just the lab sends you these little jars instead of your slides, and you basically just put your sample directly in this liquid solution. And the idea behind it is that it's the same idea. You're still doing cytology, but it's going to increase cell preservation. It decreases artifacts. You don't have to worry about making slides. And it's going to basically increase the ability to have a diagnostic sample. This is taken from that bottle, transferred to the slides once it gets to the lab, and they actually, before they transfer it, they'll actually remove a lot of the impurities. That solution is made to kind of degrade blood down and different samples to make it more accurate. This concept here, I think, and where it can be really utilized, is that when you look at this, it may offer an opportunity for us that have really tough cytologies, things that you sample and they send to you and go, we really couldn't really get anything out of it, or you're looking at it under a microscope and go, I don't know, this looks like all these cells are busted up. It's maybe worth a phone call and say, do you guys do liquid-based cytology? I don't know if we do it. And I just was reading through this stuff and go, oh yeah, I was going to ask them a long time ago if they did that. We do a lot of biopsies, but there are times where we really want something to just be cytology because it's cheaper and easier. Liquid-based cytology is where the human guys went. They don't make a lot of slides in-house now. They just do these samples and send them to the lab and let the labs do them. This is something that's going to be an option as we move forward, and you may see a lot of people start getting rid of slides and just putting it into solutions. So this study was done on lymphoma that was presented, 20 dogs. All of them were evaluated conventional smears versus liquid-based cytology. Liquid-based cytology was 100% diagnostic in all samples. It was found to be much cleaner, uncontaminated sample, no blood, cells were intact, and basically the take-home was it was just better for the pathologist to make the call. They just said they could look at the slide and go, that was liquid-based and that was somebody made that in a lab. I mean, they were that different. So we're going to end with a question I get a lot, and that is, does secondhand smoke cause cancer in dogs? And so somebody did the study and looked at it, and I thought it was interesting when they presented it, because I get that. Secondhand smoke is a known carcinogen, and it's a passive thing. Someone smokes. It's the reason we've gotten rid of so many smoking facilities and, everything from restaurants to bars to you name it. But it is known to be a carcinogen, and has been linked to primary lung cancer in people, meaning somebody smokes around you and you get the lung cancer. And so that is definitely been confirmed. But the unknown role is, does it have any effect in passive environmental exposure to dogs? So if someone smokes around your dog, they have a higher risk of lung cancer. So they looked at 3 populations, and this was basically how this went. Was a university sent out surveys to all of these dogs that had been into their hospital. It was a big population, so they found 169 dogs with lung cancer, 169 dogs with a non-pulmonary cancer, so mast cell tumors, and then 167 dogs that didn't have cancer at all. They actually were there for neurologic dysfunction on the neuroservice. And they sent them all confidential questionnaires and reassured them that don't put your name, don't put anything. We want to know what your disease your dog has and answer these things. And so this was just one leg of it. They did stuff for exposure in your yard and all kinds of stuff. But the big one was the smoke that they looked at. And what they found is that 13% of people smoked around their dogs that had lung cancer. 18% of people that smoked around dogs that had mast cell tumors, and 21% around dogs that were neurodogs. So basically it showed that there was actually more dogs that had non-cancerous diseases, neurodogs, that had exposure to secondhand smoke than ones that had lung cancer or mast cell tumors. So this really takes out that question, if someone ever asks you, does smoke play a role in lung cancer? Well, if it does, it plays a very minor role. And certainly I think it is more of a humanistic approach. For dogs to get cancer and people to get cancer, it usually is 2 different things, because as people, we are chronically exposed for years. Dogs don't live for decades, they live for a few years. And so that's probably why we see our cancers be more genetically driven, where humans may have certainly more of an environmental influence on the development of cancer. And that's why we preach so much about exposures and hazardous environments and smoking and all that stuff. Whereas dogs, it really is the genetics, and that's why there's so much of that stuff we just talked about that we're looking at to try to identify links and potentially opportunities to prevent it. Well, I thank you guys very much. I really appreciate you coming out. I know that was a little different talk. Hopefully you leave here with some new ideas and new thoughts and excited like I do when I go to these meetings, and I'll open it up for any questions that you might have at this point.